slides off the top. I thought they were pretty good. All right, so this is a guy who's an alcoholic, and this is 10 weeks after he had the disease, and he came back to your office, and you ordered a CT scan. It's got this. So you got to know what this is, all right? Now, what do you want? Are you going to needle it, ERCP, endoscopic drainage, or talk to a surgeon? Don't do anything. By the time we're done, you should be able to answer that question. Anybody want to answer any of it? Take a shot at it? All right, this is a woman. She's 65. She's got some abnormal liver function tests, got gallstones, and she's got pancreatitis. Sounds pretty uncomplicated, normal intensity. All right, so next question is, who wants a CT scan for necrosis? Who wants antibiotics for her? ERCP, better not answer. NPO, surgical consultation. You're going to be able to answer that for you. This is my question, which is more ambiguous. And one of the things we talk about when you're taking your test is why do they put these things in the question? Okay, you always ask yourself, what's the question, and why is this in there? So a 68-year-old male with nausea, vomiting, pain, past history of a cabbage, takes Plavix and aspirin. He comes in and is a little bit desaturated, heart rate's up, BMI is 33, and routine stuff there. Except for the sodium, 148, creatinine 2.5. So, have you been seeing the emergency? You're in the ER, you're seeing this patient. What's your first priority? Get the diagnosis with imaging, triage in the right place, get a consultation with surgery, pulmonary, GI, renal. Initiate antibiotics, heparin, fluids. Wake up Dr. Westerman, tell him you don't like pancreatitis. And call Dr. Wilkes to see if he'll do an urgent ERCP. All right, so you should be able to answer that when we're done. All right, so acute pancreatitis. This is going to be kind of the outline that I'll wander through. And we're also going to touch on these subjects briefly, depending on our time. All right, so you're well aware of the definition. It's pretty common. You're all taking care of patients. The mortality is a lot better. We're better at taking care of this than we used to be. The mortality is 3%. That's really moderate. That number is really not good. For mild disease, mortality is like 0. Okay? But as I'll show you in later slides, for severe disease, which you're not going to see very much, it's dangerous. You have to really get it right on that. All right, so, and the last note is that almost all the people you see are going to be mild and moderate, and the severe ones are the ones that you're going to have to be good at. So what causes pancreatitis? Well, it's really a lot of stuff, right? And mechanical things, toxic things, metabolic things. These are lists, some of which you got to have loosely in mind. I know under trauma you can barely see ERCP in there. You know, you shouldn't really want to barely include that, right? All right. So, and I know seems to me someone told me that on tests that scorpion venom is a really popular thing for a test question, but I just haven't seen that. And vascular disease, genetic things, on a rare occasion of current disease, we'll do genetic studies. That probably is a pretty good test question. Autoimmune disease is sort of more common now than it was. Renal transplant, I've never seen that. So, what's the take home from this list? Well, almost all of it is stones. And around here, alcohol. And there's another 40% that you don't know. I think that most of that second 40% are small stones that you can't see. If you don't understand it now, I think you should. Our imaging tests are imperfect, okay? They don't see everything, and sometimes the history is really the more important thing that tells you what it is. So I think that a lot of that third category are microcrystalline disease, tiny stones that are passed that you can't find. Haven't seen any scorpion bites. Hyperlipidemia, I've really not seen that very much. Thiazides and azathioprine, all of them, we don't see drugs causing it very much at all. All right, so you have pain, you have nausea and vomiting, radiates the back, so that's pretty regular stuff. And, all right, so it's kind of useful to know about the timing of symptoms when you're taking your history, when did it start, how long has it been going on. Have you had it before? And you want to know about comorbidities. If you had your gallbladder taken out, how much do you drink? Of course, your patients probably always tell you the truth, right? Yeah, right. Did anybody in your family have it? Any new medicines within the reasonable near future? Dr. Wilson must have put that out there. Exposure to a GI doctor. All right, so the physical exam is a little less important. You're interested in jaundice because you're thinking more about stones. There's at least some obstructive process. Paniculitis makes a nice test question. And within the abdomen, it's a little more useful. You know about tenderness, of course. You want to know bowel sounds is the most useful thing when you examine the abdomen. Is it distended? You very rarely feel a really large gallbladder. It's actually not very common. Is the liver big? These signs of bleeding I have never seen, but there are also useful test questions. And I don't know, one of my pet peeves is why people's names are attached to these things anyway. I think that's a really stupid tradition in medicine. I'm not lying to you. Amylase and lipase are enzymes you use. They both have fair sensitivity and some specificity, but they're not perfect. And there are other disorders that cause the lipase and amylase to be elevated. And the other thing that you should know is that following them sequentially after the patient is admitted is a waste of time. It doesn't teach you anything. So once you got the diagnosis, you might want to have the one when they're admitted and one when they go home. Every day doesn't matter. The CRP is sometimes used for some of the measuring systems for the severity of the disease. I don't use that, but it is mildly useful. If you don't know they're badly ill, then maybe you need that. I think you can pick that out. So imaging tests. X-rays and abdomen, chest X-rays and abdomen are kind of overlooked. They should be part of that evaluation. The ultrasound is going to help you about whether the gallbladder has stones in it. It's not going to see the pancreas very well, especially if they have an ileus. It's not going to see the bile duct very well, almost never does. CT scan is kind of an argument about the timing of that. Probably if you're up on the floor, they've already done the CT scan, right? Well, but there's a test question, as we'll talk about later. Maybe you really don't need it then. Maybe the best time for a CT scan is 2 or 3 days in if the patient is deteriorating. That's probably a better time for it. But I admit, it's always there to start. And I'll show you some pictures of that. The MRCP is good for bile ducts and fair for necrosis. And ERCP, if it's late at night, I always call Dr. Wilkes. And doing emergent, I've got a slide that shows you doing emergent ERCPs, it doesn't help. It's not really the thing that you do right away. And they don't go well when you do emergency. I've tried that. Okay. So the Atlanta classification is something that I think every one of you already know. The best 2 out of 3. You need 2 out of 3. And if a patient shows up in your office or somewhere else with the characteristics, pain and amylase and lipase, you don't really need an imaging test to make the diagnosis. You're going to use it for something else, fine, but you don't really have to have that. 90% of the people are going to have the criteria for pancreatitis. We got to see it up here. So 90% of the people are going to have on the first two parts of this. So 2 out of 3 for pancreatitis. With imaging, this is the slide that repeats what I mentioned to you before. CT scan does not improve outcomes, does not influence treatment, it's not superior, it's not crucial initially, but you'll already have it. On a rare occasion, it can make the kidney function worse, which is one of your major functions. All right, so one of the things that's useful is to assess severity. And so I want to convince you that it's probably useful to do that. It's going to influence your treatment, how you treat them. It's going to influence where you treat them, which is one of your big jobs. Just get them in the right spot. It's going to allow you to focus on the complications that are coming down the road, because pancreatitis has some breadth to the illness, and what goes on 1 week or 2 weeks later is not the same thing. You've got the same problems in 1 week. They're different. All right, so and a lot of what we do with these communications, these systems are for communication. So if you call me and tell me that some score, we use for liver disease, MEL score is 26, I know the disease is really bad. So a lot of the scoring systems are less useful for management than they are for communication from one provider to another. And it helps you talk to family a little bit. All right, so about the severity of the disease and the mortality. If you don't have OF is organ failure, if you don't have any organ failure, they all survive. Moderate disease with a transient organ failure, the mortality is still very low. And persistent organ failure, if you have 3 organ failures, the mortality is 60%. It's big. You're in the big league with that. Okay? So the risk factors for severe disease and poor outcome. Old people, 55 to 60 doesn't seem that old to me. Comorbid disease. So now you're seeing why I put those things in that slide I made for you. They're obese, they're old, they've had other diseases, and alcohol is a little bit more dangerous than other, OR is odds ratio. Okay. Hypertriglyceridemia, that was a surprise. That odds ratio is twice as dangerous. There are scoring systems, and you shouldn't memorize any of them. Okay. You should know that they exist. You can look them up if you need to. And I don't use them, but it wouldn't be okay if you did. The problem with the Apache and Ransom scores are, look at the Ransom score. After 48 hours, well, I mean, you've done the important stuff by 48 hours, right? It doesn't help that much to me. So anyway, there are scoring systems. If you need to communicate or use them, look them up. PSS. All right, and you know the markers of SIR is better than I do, I'm sure. The BUN is really useful. Remember that. Okay, we're going to talk about, we've got a slide for that. SIRs, you know that. All right, this is a slide that talks, and the different columns are the number of SIRS markers that are positive. And the interesting thing to me is you can see that the mortality of someone with 4 is twice what it is with 3. I mean, that's pretty impressive. So the more SIRS positive markers there are, the more dangerous it is. The ICU, that's the pancreatic necrosis story is also important. If you have 3 or 4 SIRS markers, the rate of the necrosis is much higher, which is going to speak to the later complications that you may be dealing with. All right, and this is a good slide. It has to do with the BUN, all right? You may not be able to read it. The top line is the BUN in patients who die. And the bottom line is the BUN in patients who survive. So it starts out not that different. But look what happens at 24 hours. So if you have a patient and their BUN is rising, you need to know you're in trouble. Okay? Or the patient's in trouble. And you need to be aware about that. So at 24 hours, if the BUN is higher, if the BUN is rising, pay attention to that. That's an important one. All right, triage. Obviously, one of my home base slides. Mild disease to the floor, moderate to severe. I think that moderate to severe go to ICU. And usually after 24 hours, you can separate out the moderate and move them out. They shouldn't stay there very long. So that's what your triage thinking process should be. If the beds are available, all right, so we're going to talk about fluid resuscitation, nutrition, antibiotics, when to do ERCP, and necrosis. All right, this is not a very good slide. That's what that is. All right, this is a slide about fluid administration. And the green is the less aggressive fluid administration, and the blue is the more fluid. And you see the two doses, the 20 cc's kilogram 3, and the one below that. The lower one goes with the green, top one with the blue. And what you can't see very well is in the vertical line is the proportion not improved. So the slide to the right is bad. It's usually better to give a lot of fluid. Okay? And that is, those are that's a big doses of fluid. But those are numbers you can probably keep in your head, All right, Ringer's lactate, it seems to be a little bit better than normal saline. There are a few papers that don't exactly agree with that. There have actually been another paper that was presented that the amount of fluid administration there's some arguments about these treatments. So you should know that argument does go on, but for probably Ringer's lactate high volume. All right, so the AGA suggests goal-directed IV fluid. Now, those numbers that I mentioned, those are two goal-directed. Ringer's lactate, and there's a confession that the data is limited, small studies. Who wants to study terrible pancreatitis? All right, so my suggestion is that you bolus all three, mild, moderate, severe, while you don't know which one they are. And that you do it for 6 hours, and then you reassess. If they look like mild disease, or they've got or they're having heart failure, other problems, if they're having problems with their fluid, you may have to back up, okay? So I reassess after 6 hours. So the idea is, they're not on automatic pilot. You got to pay attention to these folks for several hours to make up your mind where you're going with this. There's another point that doesn't come up very often. And a real failure of fluid administration is if the patient remains hypotensive and their kidneys die. That's failure. If they develop respiratory failure, but their kidneys survive, that is not failure. You can ventilate them, and some people say if you haven't put them on the ventilator, you haven't given enough. So, you protect the kidneys and the heart before the lungs, because you can put them on the ventilator. It's an okay thing to do. That's not a failure. And that's, unfortunately, had to do that a couple of times. It's not common. All right, that's the fluid story. Nutrition. Not that I'm much of an expert on nutrition. All right, so early feeding is good. I think you probably all know that. We were trained not to give them any food or fluid. That's wrong. A lot of things I was told were probably half the things I'm telling you today would be wrong in the future. So it looks like feeding improves the gut barrier, reduces infected necrosis. That's pretty well established. So feed them as early as they can take it. Okay, if they're vomiting, you don't feed them, right? But if the vomiting is better, you ask them what they want. If you have to supplement them, nasogastric, nasoenteric, they're the same. There's no evidence that a nasoenteric tube is superior to a nasogastric tube. All right, avoid NPO, feed them when they want it. Antibiotics. There have been a lot of studies on antibiotics. And I know they already gave it the emergency room, but there's not a lot of evidence that makes any difference at all. Okay? So you should reserve for people that you are convinced have cholangitis, or you think they have infected necrosis. Oh, you just met them. You don't know if they got infected necrosis. All right, so be aware that there's not, if you give them antibiotics, be aware you don't have a lot of data to back that up. That's probably a pretty good test question. All right, there have been a few studies on early ERCP, and gratefully they think it's a bad idea. Who wants to do an ERCP in the middle of the night? Well, on a patient in shock. Terrible idea. So, are there any people that you do that on? Almost none. If you're convinced that the dominant event was cup infection, suppurative infectious cholangitis, then maybe. All right, fluid collections, and this is a useful thing. All right, so most of the pancreatitis that you see is interstitial inflammation, right? And then some of it will be necrotic. You'll get into that. The fluid collection with interstitial is an acute pancreatic fluid collection. And the time frame you see in the other is acute necrotic. If it's less than 4 weeks, it's acute, okay? Over 4 weeks, it's not. Over 4 weeks, they call it a pseudocyst. If it's interstitial, if it's necrotic, they call it a walled-off necrosis. One is a strange image. Walled-off necrosis. All right, this is, I don't know if you can see that very well in the back, but the arrows are pointing to a diffusely inflamed pancreas. And you should be looking at these CAT scans. Make yourself look at them and find out what they're talking about, so you can be good at it later on. Everyone can see the pancreas. Bad touch. All right, so this is an acute pancreatic fluid collection. The pancreas is diffusely enlarged and involved, and you see the fluid density around that. This is going to be a really common thing that you see. All right, so, and the label at the top is mine, and it's incorrect. Obviously, if it's a pseudocyst, it's not acute, right? It's 4 weeks later. And what they're pointing to by the wall is thick. So this is a pseudocyst. All right, this is back to acute necrotic event, and you see that there's no pancreas, it's gone. You can't see it anywhere. And all you see is this homogeneous mess over here with the air area. This is acute necrosis. Not good. And this is a blurry MRI. All right, this is walled-off necrosis. Now, what's the difference between this picture and the acute necrosis? 4 weeks, right? Okay. This one, it's been in the hospital for a month, and now you got this. The other one was in the hospital for 2 weeks when you got that picture. It's a different time. All right, so this is walled-off necrosis.
On TB, how do we differentiate between walled-off necrosis and cirrhosis?
It's the surface around it. Plus, the pseudocyst came from a patient with interstitial disease, not necrotic disease. The walled-off necrosis came from someone with necrotic disease. So, but you see there's no rim around this. There's no thick pseudocyst around it.
Is there any pancreas tissue in that CT scan?
Sorry?
Is there any pancreas tissue in that CT scan,
I don't know if that little light area on the other side, probably not. But if there is, it's just a little bit of the light side. Most of it's gone. Yeah. In a big way.
What is this homogeneous opacity?
That's the walled-off necrosis in the middle. That's what used to be the pancreas. And then the necrotic tissue is collected there with pancreatic juices and is surrounded by a very thin membrane, not a thick pseudocyst. All right, this is the really bad one. So this is the walled-off necrosis picture. All those bubbles, that's iron. You're in real trouble. Okay. Sorry, I don't want that picture. I'm doing my best here, and it's not very good. All right, I hope you never see that. All right, so there's a good bit of ongoing argument about how you take care of infected necrosis. And so the infected necrosis is usually not 1 week. You're usually talking about 3-4 weeks into the illness. A really sick patient, you've been keeping together, and now they got this necrotic pancreas, and now you've got air in it, you got infection. So what do you do about that? All right, so then the argument has been, obviously they're on antibiotics already, but the argument is drainage. Do you start with the most aggressive drainage, you just cut them open and do surgery first, or do you start with the less aggressive measures like radiology or endoscopic drainage, and then work up to surgery if that fails? And there's been something of argument about that. Step up versus step down, and since most of these are done by gastroenterologists, well, the issue is that there's not any real difference in mortality, that they both do only fair, but the length of stay is much better with the endoscopic percutaneous drainage than surgery. And it's fair to say that we don't offer that in our hospital. And it's fair to say that our surgeons won't touch the pancreas. They're running as fast as they can away. So by the time you're into this set of decisions, you're presented into a center that has a higher level of intervention that we provide and surgical backup that we don't provide. They're being transferred. All right. So, summary of that. We got to have a bigger place for sepsis. Talk about gas. I really would love to try one to drain one of those. It looks pretty easy to do, really. All right, so taking home, one point to take home, statistically, if you advise the patient to stop drinking and smoking, supposedly they do better. I have no idea why that makes any difference, but it's a quality measure. So you're going to want to put that in your note. For readmission, the interesting thing is about cholecystectomy is that if you do the in-hospital cholecystectomy, the readmission rate's cut in half. Pretty impressive. So if they have stones and they get over their disease, they should have their gallbladder taken out before they go home. the interesting question is, what do you do about the 40% that you don't know? And I think